Thank you. Can everyone see my slides and also hear me?
Yes.
Yes.
Thank you. So thank you for having me. It's a real pleasure to be here today. I think my talk is going to be really complementary with the one that Liz just gave. She gave a really fantastic overview of kind of the state of the literature in this topic. And what I plan to do is actually really focus in on clinical implementation and how to, in this sort of more immediate intra and perioperative period, how to try to make some progress on improving our care for older surgical patients. I don't have any conflicts of interest to disclose. I do have a small pilot grant from NIDIS to work on related delirium research. So over the next 50 minutes or so, I'm going to just really briefly go over a few key points, not to rehash anything that Liz just went over. And I'm going to spend most of the time here on how we developed, implemented, and evaluated the impact of a delirium prevention intervention at my institution. And finally, I'll finish up with some practical advice about lessons learned along the way for how somebody might want to approach this at your institution. So to frame this and to kind of bring this back to why this is important and who really has the most at stake here, I'm going to talk about a case that I encountered probably 2 years ago while I was the ICU attending at one of our smaller surgical subspecialty hospitals. There was a 78-year-old woman who had a history of mild cognitive impairment, alcohol abuse, and several medical problems, who had a laparoscopic self-injectomy for resection of a large ovarian mass. Postoperatively, over the first few days, she developed agitation, combativeness, and tachycardia. On the fourth post-op day, I was called by the surgical team to evaluate her for ICU transfer because she had developed, quote unquote, alcohol withdrawal. I went to see the patient, and she was indeed confused, agitated, combative. She did not have any focal neurologic deficits. And really notably, she didn't have any of the sort of hallmark, more specific findings that you would see in somebody who is suffering from alcohol withdrawal, such as tremulousness or diaphoresis. She was tachycardic, she was hypertensive. Reviewing her lab, she had developed a pretty significant AKI postoperatively. And I really felt, based on my evaluation, that the surgical team had misinterpreted her clinical syndrome as alcohol withdrawal. So I asked her nurse to do a delirium screen. We used NuDesk at our hospital, and it was consistent with delirium. So I diagnosed the patient with hyperactive delirium. I dug a little bit deeper into her chart, and I saw that over the last 24 hours, she had gotten 8 milligrams of lorazepam because, again, the surgical team thought she was in alcohol withdrawal, so they were trying to treat that. For sort of ERAS, postoperative nausea, vomiting prophylaxis or treatment, she had gotten 10 milligrams of prochlorperazine, she had gotten 10 milligrams of metoclopramide, 30 milligrams of PCA by morphine via PCA, and 600 milligrams of gabapentin. None of these things were pre-admission medications for her. So I did some education with the team. We really focused on non-pharmacologic delirium precautions, did not transfer her to the ICU, and pulled all of these medications off of her list. Over the next several days, she had a really unfortunate course. She continued to be agitated. She ultimately lost her IV access. Everyone in the hospital, including myself, tried to establish IV access, but just coming close to her with an IV was so disturbing to the patient that she and ultimately her family refused additional attempts at establishing access. She then went on to have a surgical complication, developed sepsis with multi-system organ failure. We were not able to give her fluids and antibiotics in a timely fashion because of her IV access issue, and she was ultimately transferred to comfort care. So I think this is a case where you can really see in this case how delirium directly contributed to a poor outcome after surgery. And it's this kind of patient that has kind of inspired me to work on this on a clinical level. I think this case demonstrates certainly that this is an important and in some cases, preventable problem. Um, So again, I'm gonna just go through a couple of definitions, et cetera. You've already heard this. Delirium is an acute disturbance in cognition, attention that's not explained by underlying neurocognitive disorder, and is a direct consequence of a medical condition, substance intoxication or withdrawal, and or toxin exposure. It's part of a spectrum of perioperative neurocognitive disorders that all have sort of a different timeframes of typical incidence and resolution, but there's no specific easily defined start and end point for most of these. Delirium is very common in surgical patients. We typically think of up to 50%, but as Liz already showed, some reports are even higher than that. In ICU patients, the prevalence and incidence is even higher than that, 80 to 85%. It's a clinically important problem. There are a variety of patient harms and increased costs that it has been associated with. Whether or not there is a cause and effect in some cases is not actually shown. Some of these things probably happen in the same patients. Some of these things are probably caused by delirium, and for others it's unclear and still being looked at. But I think, again, bringing it back to the patient and the family, this is a really impactful problem for people to go through. These are some quotes from an article in a nursing journal. One person says, "My mother wasn't there at all, not at all, it's a shell. My father would just look at me and there was nothing in his eyes, nothing, no recognition, just dead patches in his eyes." These obviously say a lot more than, from a personal experience than we can get from, reading a study. A patient who went through delirium talks about how the color purple was frightening to her, and really just talks about many of these disturbing experiences that patients who have delirium go through. And these have been associated with a long-term sort of psychological consequences like PTSD. So my question is, if you are an anesthesiologist who is in the preoperative area to evaluate this patient, you can just look at her and see that she's at high risk for developing delirium. She's elderly, she has medical comorbidities, she has mild cognitive impairment, maybe doesn't speak English, and she's having a high risk surgery. So if you are kind of the day of surgery anesthesiologist, how do you optimize her care to give her the best chance of avoiding things that are preventable, and so hopefully by extension maintaining her current level of function and independence? So next, I'm going to transition into a behavior change intervention that we undertook at UCSF, because implementation of all of this sort of evidence that we have in the literature requires providers to change their behaviors and to follow the recommendations that exist in the literature. So with the patients that I've already discussed in mind and many, many others, as I said, I set out and my team set out to design a behavior change intervention to make our perioperative care look more like the care that's recommended in best practice guideline recommendations. And so I'm going to frame this in sort of in the context of an implementation science intervention. This is one implementation framework that exists in the literature where you should consider steps involving pre-implementation planning, designing the intervention, followed by evaluating the intervention. So I will take you through sort of each of these steps, starting with pre-implementation planning. Of course, there are multiple sub-steps associated with each of these. And with thinking about pre-implementation, it's important to have a good understanding of what is the evidence that you want to translate into practice. What is the gap between what the evidence says we should do and what we actually are currently doing? And in addition to that, what benefit what would be the impact if you were to change practice and close that evidence practice gap? So that could be improvement in patient outcomes, cost savings, whatever outcome you're interested in. You need to think about who the stakeholder communities are. And again, that can be anybody from providers to patients and families to thinking more broadly, department and hospital leadership, patient safety and professional societies or policymakers. And then you need to think about, is your institution ready for change? So starting with what is the evidence? Before I get into this next slide, it may be easier to just state that, as Liz already went through with you, there's not a lot of evidence for supporting individual practices in the immediate perioperative environment that will reduce postoperative delirium. So there's been a lot of really great work going on in this area. But unfortunately, most of the studies that have been coming out have been negative. So these are a few examples: intraoperative infusion of dexmedetomidine, inhalational versus IV maintenance anesthesia, gabapentin perioperatively, EEG-guided anesthetic administration, although we have an update that we just heard about on that, regional versus general anesthesia or intraoperative ketamine. Unfortunately, the studies listed on this slide, none of them showed a significant reduction of postoperative delirium by using these strategies. So what we're left with are a variety of guidelines that have been published by professional societies. You'll notice that these three are a little bit older. These were the guidelines that existed when we set out to develop this intervention. This one is from the American Geriatric Society, a best practice statement for postoperative delirium reduction in older adults. There is one from the AGS and NSGWIP about sort of more global management of the geriatric surgical patient. And then, of course, the 2015 Beers criteria, which has now been updated to the 2019 Beers criteria. I'll spend some time on this a little bit later. Subsequent to those studies, there have been a variety of others. Liz already went through all of these, and I acknowledge that there are many more out there that I do not have on this slide or in this summary table, but these are sort of the main guidelines that we reviewed in thinking about what our perioperative intervention would be. And so these all address sort of slightly different things, and many of them have a slightly different focus. Not all of them are directly focused on reducing delirium. But things that are common themes include a multi-component intervention, recommended by almost all of them, performing preoperative cognitive screening, recommended by all of them, recommending or considering depth of anesthesia monitoring, simply because I think the experts in the groups feel like it's the right thing to do, even if it's not necessarily well supported by randomized controlled trial level evidence. Regional anesthesia, I think, likewise, is something that people aren't willing to say don't do it. So they say things like unable to recommend. So there's not strong evidence suggesting that regional anesthesia will reduce postoperative delirium, but again, it may be still the right thing to do for certain patients. Maintenance of cerebral perfusion pressure is something that is gaining sort of increasing levels of recognition as something that might be important. So it's recommended in a couple of our newer ones. And then in terms of medication management, most of them discuss avoiding high-risk medications. I will go on to talk about those high-risk medications in a little while. So in thinking about sort of just giving you a summary of these best practice guidelines, so delirium is thought to occur because patients bring in extrinsic risk factors to surgery with them. Some of these are modifiable, most of them aren't. In addition to that, we introduce them to a variety of perioperative insults, and those intrinsic and extrinsic risk factors combine to result in delirium. Most of these best practice guidelines are geared towards reducing those perioperative insults to try to reduce the incidence of delirium postoperatively. Moving on next to thinking about the gap between evidence and practice, we really didn't have a good understanding of sort of what was going on in a more global sense until just recently, when members of the ASA Committee on Geriatric Anesthesia and the Brain Health Initiative conducted a survey of ASA member anesthesiologists in the United States. They asked them questions about how frequently do you perform these 6 items that are recommended by at least one practice recommendation. And they could respond rarely or never, frequently or occasionally, or usually or every time. So the thing that people are doing most frequently is providing older patients multimodal analgesia, followed by providing them with information about delirium and postoperative decline. Things that are happening very, very infrequently are performing frailty assessments, comprehensive geriatric assessments, preoperative cognitive assessment, and even screening for delirium postoperatively. So you can see that in terms of sort of coming up to speed with what we know or what we think are best practices in postoperative delirium prevention for surgical patients. Sort of we, on a more global perspective, have a long way to go in improving our practice. A little bit more anecdotally, at my institution, we looked at a 1-year baseline between 2016 and 2017. About a third of our older patients were getting at least 1 Beers criteria medication in the immediate intraoperative period. And at that time, we were not doing many of the other things that are recommended by these guidelines. Here's some more anecdotal evidence. 2 patients that I took care of that, again, these patients just kind of stick in my mind as like, we can do better. So there was an elderly patient who we were bringing down from the ICU for a 2nd stage spine surgery. When we picked her up in the ICU that morning, she was already confused. She was a little bit sleepy. She had been CAM positive. She had been receiving Dilaudid PCA. The anesthesia provider I was working with that day administered her 2 milligrams of midazolam in the elevator. She, after that, stopped breathing, and we had to mass ventilate her into the OR. Once sort of the chaos settled down, she looked at me and said, "I guess she didn't need that Versed, did she?" And obviously she didn't. And I think just avoiding these kind of knee-jerk reflexes of treating all patients with Versed or other medications just because that's what we do, I think is really necessary. Final patient, an 86-year-old who was coming in for ambulatory surgery, a quick come and go DNC for postmenopausal bleeding. Before I had evaluated her, she had already gotten diclofenac, gabapentin, and scopolamine per our ERAS protocol ordered by her surgeon. So I put on a glove, I took off the scopolamine. I couldn't do anything about the other things, but I don't want anybody to misinterpret. I think ERAS protocols are great, but I think any type of care that's administered without thinking about sort of specific patient-specific consequences of doing that is not necessarily the best thing. So I don't think this 86-year-old patient needed 3 high-risk medications to sort of have her go out the door, get confused, have blurry vision, and fall down and have more complications. So finally, transitioning or moving back, you have to think about, is our institution ready for change? And when we designed and developed this intervention, we had a really robust delirium hospital-wide infrastructure going on at UCSF. There was a delirium quality improvement effort going on where all patients on the floors were receiving risk stratification. They were receiving delirium screening every shift on acute care floors and in the ICU. There were pathways and order sets in place with many of the components that Liz suggested, early mobilization, pharmacy review of medications, et cetera. And then there was a pretty strong group of people across the hospital that were working together to try to coordinate this large-scale effort across the hospital. It's also important to think about kind of individual level barriers. For example, support that you may or may not have from leadership or the institution, buy-in from staff that you're trying to get involved. And in some cases, in our case, electronic health record infrastructure was really important. I think I will skip this. This was just meant to further elaborate on the fact that we had a hospital-wide delirium reduction campaign underway. All right, so in designing the perioperative intervention, we thought about the evidence that I just presented to you. In some cases where evidence is gray, when you're really thinking about what should we do for individual patients, we had to establish group consensus with local experts. We really considered feasibility and sort of momentum that had already been established by this hospital wide quality improvement effort. And so as I describe what we did, you might notice the sort of feasibility and institutional momentum being pretty large themes in what we ended up doing with our intervention. So we've already discussed this almost ad nauseum now, but I just want to point out that we decided to focus in on the two things: multi-component interventions and avoidance of deliriogenic medications or Beers criteria medications and polypharmacy as the two interventions that we were going to focus most on for the immediate perioperative area, because we felt that those had the best sort of support by the evidence. You heard about multi-component interventions. I won't go through those again. The American Geriatric Society first published the Beers criteria in, I believe, 1991. This is a really comprehensive list of potentially inappropriate medications that should be avoided in older adults. It's really quite well established. It's considered gold standard in the geriatrics literature, and it's widely used by clinicians, educators, researchers, et cetera. The Beers criteria gives recommendations in sort of 5 categories. So generally speaking, medications that should be avoided in all or most older adults, those that should be avoided in older adults with specific conditions such as delirium, drugs that should be used with caution, drug-drug interactions, and drugs that should be dose adjusted based on kidney function. Because medications are, which medications are available to you really highly depends on geography. There are many, I wanted to point out that there are many other lists similar to Beers criteria that exist. We obviously use Beers criteria because I practice in the United States, but if you live in a different area of the world, there may be a list that is more pertinent or relevant to your practice. These are some screenshots from the Beers criteria. So this table points to medications that should be avoided in patients who are at high risk of delirium. And I've put arrows next to the medications that we typically use in the perioperative area. So anticholinergics are a really big offender. This table to the right sort of breaks down the anticholinergics, and you can see here that they're in the category of antiemetics. Many of our commonly used antiemetics, prochlorperazine, diphenhydramine, hydroxyzine, scopolamine, have really strong anticholinergic effects, and in most older patients should not be used. Benzodiazepines are listed here, corticosteroids, meperidine. Antipsychotics, I have kind of a dashed arrow to. In response to a question that came up earlier, antipsychotics are recommended to be avoided because of more over the longer term because of increased risk of stroke, cognitive decline, and mortality in patients with dementia. And then it's recommended that these should be avoided for behavioral problems such as delirium or dementia unless non-pharmacological options have been exhausted. So, antipsychotics generally should not be given as a prophylactic medication for delirious patients or even to treat delirium unless they are exhibiting behavioral problems that represent a harm to the patient or to staff members. And then I also wanted to point out that for short-term use as an antiemetic, that might be considered an acceptable use of these medications, for example, haloperidol, which you'll see in our protocol later on. This is a sort of more expanded listing of medications that are on the Beers criteria that we commonly use in anesthesia. Again, anticholinergic should be avoided because of confusion, dry mouth, constipation. Benzodiazepines should be avoided unless you're treating something like seizure disorder, alcohol withdrawal, because of increased sensitivity, decreased metabolism, increased risk of cognitive impairment, falls, delirium, and fractures. Metoclopramide should be avoided unless it's used for gastroparesis and or used for a very short period of time because of its increased risk of extrapyramidal side effects. Muscle relaxants generally should be avoided because of anticholinergic side effects and risk of sedation. Non-steroidal anti-inflammatories should not be used chronically, and you can think about dose reducing them. Higher risk of GI bleeding, hypertension, acute kidney injury. Ketorolac is specifically listed as something to avoid. Opioids should be avoided except for management of severe acute pain, avoided in patients with history of fall or fractures, and should not be used concurrently according to these guidelines with benzodiazepines or gabapentin. Meperidine specifically should be avoided because of its risk of neurotoxicity, including delirium. Tramadol is another one that has adverse central nervous system effects and should be dose reduced for patients with reduced kidney function. Gabapentin, the guidelines say to dose reduce them for GFR less than 60 because of adverse CNS effects, and usually specifically talking about sedation. So at the end of our sort of data synthesis, this is kind of an infographic of what our recommendations looked like for pre, intra, and post-op care for patients who are at risk of delirium. And so you can see here that we recommend just sort of generally good practices in terms of multimodal preventative measures, avoiding polypharmacy. I will break down these medication recommendations over the next 2 slides. Preoperatively, we implemented a delirium risk stratification procedure with an AWOL-S tool, which I will talk about in a little bit more detail in a moment. Intraoperatively, you'll notice that these guidelines are really just kind of best practice care for most patients. We don't sort of really put our nickel down on any specific thing that you should do intraoperatively. So, dose reduce medications, maintain hemodynamic stability, consider using EEG guided depth of anesthesia monitoring, use multimodal opioid sparing analgesia, use neuraxial regional techniques whenever it's appropriate. And then post-operatively, we recommend using a delirium specific PACU order set that I will go into in a bit, and communicating with surgeons, nurses, and others about patients' post-operative delirium risk. So for medications, we do give some specific guidance for how to use medications or what to be concerned about with specific intraoperative or perioperative medications. I've already gone through this list in kind of the Beers criteria table. Postoperative nausea vomiting, I think, is a really challenging problem in this patient population, because as I pointed out earlier, most of the antiemetics that we have at our disposal have some kind of anticholinergic properties. And so we sort of assembled a kind of an expert group, including geriatricians, neurologists, pharmacists, and then our kind of surgery and anesthesia perioperative team, to talk about what should we actually recommend for patients. So first of all, we recommend preventative measures, propofol infusion, aprepitant as examples. Second line agent would be ondansetron. We recommended haloperidol as the third line agent, followed by a small dose of metoclopramide one time only. We asked for the medications on the right side of the screen, which all have anticholinergic or other, potentially inappropriate side effects, to be avoided whenever possible. So to put all of those recommendations into practice, we then designed a behavior change intervention that had 5 components. So we introduced preoperative delirium risk stratification so that people could know who's at high risk of delirium. We provided a lot of education. We provided sort of written memory aids, posters, infographics, all of those types of things, so that they would be widely available. And we developed a new PACU order set, which had removed some of the high-risk medications for older adults and made a number of enhancements to our electronic health record to sort of help guide people in doing the right thing. I also wanted to just sort of remind everyone that this was aligned with a hospital-wide delirium quality improvement effort. So most of the sort of care after the PACU was directed by sort of the leaders of the hospital-wide effort. The goal of our intervention was to change practice or bring our perioperative delirium prevention practices in better alignment with these recommendations. It was not necessarily to demonstrate a reduction in delirium for very complicated reasons. We had a lot of things going on at the same time in our hospital, and we did not think that it was feasible to actually be able to demonstrate that delirium rates were diminished by our perioperative intervention. So the first part of this was delirium risk stratification. We chose to use a tool called AWOL-S. This is something that we actually developed. It's a risk stratification tool that's embedded into our electronic health record and performed by preoperative nurses. The components of this risk stratification tool are the patient's age, their ability to spell world backward, whether or not they're oriented to place, their illness severity score, which is their ASA classification, a marker of the specific risk of the surgery they're undergoing. And then, so the EHR takes all of these into account, uses a logistic regression model to predict the probability of delirium for an individual patient. So we get a notification of when a patient has high risk or not high risk. We provided a lot of education to nursing, anesthesia, surgery departments by way of staff meetings, grand rounds, emails, lots of other sort of forums that we could. We developed a number of memory aids. For example, this is a card that we posted on the intraoperative anesthesia carts to sort of remind people of which medications we suggest that they give or avoid. We posted these cards on the PACU nurses' kind of computer stations to remind them about what the non-pharmacologic interventions are and to remind them to discuss with the nurse that they're signing out to about the patient's delirium risk. We sent a lot of reminders. We gave performance feedback to all of these groups. So it was really quite a labor-intensive project that required a lot of education. This is the kind of a snapshot, parts of the delirium risk PACU order set that we developed. These are just portions of our PACU order set, but you can see that there's an area for patients who have standard delirium risk versus high delirium risk. And in the high delirium risk area, your options for treating postoperative nausea vomiting are Zofran and haloperidol. We removed meperidine, prochlorperazine, and metoclopramide as options from the PACU order set. And then we introduced non-pharmacologic delirium prevention interventions to start right away in the PACU. Electronic health record enhancements were actually a really important part of this project. We needed a way to communicate that a patient was at high delirium risk. And so this blue rectangle is the patient's banner that's sort of at the top of their chart. There is this yellow anesthesia caution flag, which if you dive into it, will show you that the patient has a high delirium risk. There are various other places in the chart where this is also indicated. We implemented intraoperative reminders to fill out the appropriate order set for appropriate patients, and sort of a checklist kind of at the end of the case if you haven't filled out the delirium prevention interventions in appropriate patients, you get a little reminder to do that. So to evaluate the effect of our implementation strategy or intervention, we looked at a variety of both process and outcome measures. For process measures, we looked at frequency of delirium screening in the preoperative area, frequency of high-risk delirium screening, compliance with the appropriate order set in the inappropriate patients. And for outcome measures, we looked, so our primary outcome was use of potentially inappropriate medications in older patients between anesthesia start and PACU end. We chose this as our primary outcome because we felt that this was something that would allow us to measure whether or not there was a change in practice between pre and post intervention periods. Our secondary outcome was the incidence of delirium for those staying at least one night. And again, we didn't actually expect to see a change in our secondary outcome. The timeframes that we evaluated were a 1-year baseline between 2016 and 2017, where we were not doing any focused delirium reduction efforts. Our sort of intervention, which was kind of considered almost a washout period, was a 6-month period of time where we rolled out this pathway. We introduced the Delirium Risk PACU order set, but we were not doing a lot of education or behavioral intervention. And then in July 2018, we started kind of our department-wide QI project with the active department-wide education on delirium and use of these potentially inappropriate medications. The electronic health record enhancements were also available at this time. So we really compare kind of the baseline to the quality improvement time periods in our analysis. Here are our process metrics during only the quality improvement interval. Delirium risk stratification with AWOL-S by the end of the project was happening approximately 80% of patients. Obviously, there's a little bit more work to be done there. About 40% of our patients were screening at high risk for delirium. Use of the appropriate PACU order set in high-risk patients. Our baseline in month 1 of the quality improvement project was only 19% of patients. And by about 6 months into the project, we were up to about 80%. Pretty consistently. The electronic health record reminders, interestingly, were actually the thing that seemed to improve our compliance the most. Our outcome measures were, so these were measured using a segmented regression analysis. So we essentially compared, we compared, just to keep it simple, so the number here is the adjusted odds ratio per month of the intervention, comparing the intervention or the quality improvement period to the baseline period. So during the baseline period, Beers criteria medications were given to 33% of patients over the age of 65, compared with 27%, compared with 23% in the quality improvement project. To adjust for secular trends and differences in patient population, we did this with a segmented regression analysis, where essentially the slopes of the in the baseline and quality improvement periods were compared using kind of a difference in difference technique. So there was, you can read this as there was a 3% per month reduction in use of potentially inappropriate medications during the quality improvement period. And that difference was statistically significant. We did an exploratory analysis to see sort of what probably drove that difference. And really, we think that the decreased administration of midazolam probably drove most of that difference in the composite outcome. Delirium happened in 7.5% of our admitted patients in baseline versus 9.2% versus 8.5% in the quality improvement period. There was no statistically significant difference in delirium incidence, but again, for sake of time, I won't go through this in detail, but there were so many things happening across the hospital during these 3 time periods that it's really actually not it wouldn't be fair to compare delirium incidence. For example, we weren't screening on a hospital-wide basis during the baseline period, so delirium is probably drastically undercounted in this baseline period. Sorry. Okay, so the conclusions from our intervention are that a targeted behavioral intervention led to successful process metrics like implementation of delirium risk stratification and use of a PACU delirium risk order set in appropriate patients. It led to a change in prescribing practice of these potentially inappropriate medications. We were not able to draw conclusions on the clinical impact. But I think, we learned a lot of things, and we still feel that it was an important intervention because I think you can argue that potentially on an individual patient level, improving their care and providing them with care that looks more like what's recommended by multiple different best professional societies is probably the right thing to do, even if we couldn't directly show that there was a reduction in delirium. So, many people are interested in doing something similar at their institution. And so I have, assembled a few lessons that I've learned and things that I've learned through kind of going through some implementation science training. So first of all, it's really important to engage leadership very early on in the process so that you have high-level support for these types of things. It's really important to evaluate what the barriers and facilitators are at your institution and to think about your institutional culture. Are you in a place where delirium is even on people's radar? Are you trying to tackle sort of more basic things like decreasing surgical wound infection rates or, something like that? So is your institution even at a place where delirium can be a thing that, people care about? It's important to get buy-in from a lot of different stakeholders, in particular for us, obtaining buy-in from the nursing staff who was going to be performing the delirium risk stratification was a really key step. And getting and maintaining buy-in from members of the anesthesia department who were being asked to change their practice was also really important. Physical and human resources are different at every location. You can see that, our project was really heavily relied on electronic health record enhancements that may or may not be feasible for you at your institution. And then it's important to think about the individual level barriers. What do people need in order to start changing their practice? Do they even know what delirium is? Do they know which medications are bad for older patients? Do they know all of the other sort of best practices that are recommended for people who are at high risk delirium? So it could be knowledge, it could be willingness to change, it could be a variety of other barriers that exist, in the providers that are going to be providing frontline care at your institution. So if somebody else was going to do this at their institution, this could look very, very different. You might choose, most people, everyone would choose a different risk stratification tool, timing, how you provide education to providers, which specific medication recommendations you provide, how you communicate among providers, your specific intraoperative recommendations, and how you manage these patients in some kind of a pathway or a coordinated care strategy after surgery might all be very different. I want to acknowledge that there are a lot of limitations to what I'm presenting today. We took a very, very pragmatic approach so that we could gain traction in the intraoperative period and align our project with what was going on at a hospital-wide level. I really applaud Liz and her team for the large-scale trial that they're doing. I think that's really kind of the right way to go about this. Delirium is really a much more global problem than sort of just an intraoperative problem. So, all of these other things that are listed on the slide for us are particular limitations and are things that we're continuing to work on. These things are really labor intensive. So sustainability is an issue, and sort of generalizability from one institution to another is also a consideration. So My recommendations are to take a systematic approach and thinking about the different steps that are involved in designing an intervention, obtain high-level buy-in, and collaborate with other departments and other professions within your hospital. And then, going back, kind of zooming out a little bit, we've been talking all day about the fact that there's not a lot of evidence supporting specific care interventions that are, supported by high-level data. So we need further research to kind of take what we're recommending from the expert consensus level to, actually based on good, high-quality evidence. Thank you.
Thank you. Thank you, Dr. Donovan. I'd like to open it up for questions for Dr. Donovan. So I have a question. Well, actually, first a comment. First of all, excellent presentation. Thank you so much. And congratulations on the success of this project. Over 80% compliance in that short of a period of time is outstanding. My question is, how much buy-in did you get from the primary services, surgeons, intensivists, et cetera, in helping you carry out this protocol after the PACU?
Yeah, that's a great question. And I would just say that is like absolutely critical to trying to do an intervention like this. Obviously, you can try to do sort of best practice care inside the operating room, but if it's not going to continue postoperatively, it's questionable whether or not it's actually going to have an impact. The bulk of the kind of collaboration with surgical departments and departments outside of the immediate intraoperative area was done by kind of the hospital-wide delirium reduction campaign. So, kind of the larger story is that the delirium reduction campaign started, I think, in 2016, rolling out delirium risk stratification and regular screening for delirium across the various floors in the hospital. This was already being done pretty well in the ICUs at our institution even prior to that. And so starting in 2016, we, on a rolling basis, began performing the new desk screen for patients every shift to determine sort of when or if they develop delirium. And for patients who screen positive or high risk via new desk, they would be entered into a pathway that was pretty highly coordinated with sort of an automatically generated pharmacy consult to look at their medications, automatically generated PT/OT consults, notification of the primary team to do kind of the workup for delirium, including, thinking about metabolic disturbances, underlying causes, et cetera. So that was happening on a pretty large scale in our hospital before we even started the perioperative intervention. So residents in our institution select a yearly quality improvement project. And actually that specific year, many of the surgical departments, including neurosurgery, general surgery, I think head and neck surgery, several others actually chose doing delirium order sets on a specific percentage or all of their older surgical patients as their quality improvement target for the year. And so just, kind of institution-wide, there was a lot of momentum and the surgeons were already pretty highly engaged in this project. So I personally can't take any credit for that, but I can say that I sort of shamelessly used the momentum that was going on to, hopefully make our project more successful down in the perioperative area.
Perfect. Looks like we have a question from Dr. Saraf, who's asking for procedural sedation preoperatively. What are your thoughts for using either low dose benzos versus fentanyl?
I do not necessarily have a problem with low-dose benzos or low-dose opioids given in sort of very limited doses. I actually just did some cataracts yesterday and found myself giving 3.5 of Versed to like a 84-year-old, and I felt not good about it. But she did great, and she left the PACU. So, I think for really kind of well-established, like minimal intervention, sort of come and go procedures, a single dose, a small dose, is not necessarily going to place the patient at, hugely greater risk. But I think if there are alternatives available, it would be good to consider them. For example, in vascular surgery patients, I have almost routinely switched to using Precedex instead of some of these other medications, because I just think it works much better and helps them remain more compliant and easier to control during MAC cases.
So on that score, I'm not familiar with the Beers list that the AGI publishes. Is any of the evidence for avoidance of those drugs actually coming from the perioperative space? Because my sense is that, some of the changes you made in your order sets, avoidance of meperidine for shivering, which is usually like a 25 milligram single shot, maybe 50 if you need to repeat it, or low dose dexamethasone for PONV. I'm not sure. I'm just not aware of that there's evidence saying that those actually contribute significantly to delirium in the short run.
Yeah, I think it's a good question, and a little bit of almost a theme of today. Does some opioid in the OR make the patient at high risk for pain issues later? Does one dose of meperidine or one dose of Versed perioperatively make the patient at risk for delirium? I'm not sure. I agree with you. I'm not sure if we know that. And the Beers criteria are based, I think, primarily on kind of a medical inpatient population. I think that, like, for me, whatever we can do to thoughtfully approach it and to sort of minimize the number of new medications, or to sort of without a need for it to give these high risk medications, I think that's beneficial for patients. For example, the patient example I gave that got Versed in the elevator, that was just a knee-jerk reaction. She didn't need it. So making people more thoughtful about how they administer these high risk medications, I think is really important.
Looks like we have a hand raised from Talmadge. Talmadge, are you there?
Yes, thank you for great talk, Dr. Donovan. I wanted to just ask, are you aware of any data that has examined whether there are differences in the incidence of postoperative delirium as a function of whether a short-acting opioid like remifentanil is used compared to a longer-acting drug?
I'm not aware of any. I see Liz shaking her head too, so that's always reassuring to me.
No, I'm not aware of anything, but most people undertaking delirium research studies wouldn't do a first delirium assessment until the day post the day of the surgery, so on day one. So it may be that if there is a difference, we're missing it.
I see. Yeah, that makes sense. Thank you. I just want to be sure I hadn't missed anything, because I was curious about the possibility.
All right. Dr. Donovan, once again, thank you so much. It was an excellent talk. We really appreciate it. Thank you. So that concludes our lecture sessions for the morning. We're going to move on now to our moderated poster sessions. We have a total of 11 excellent abstracts. The format of these poster sessions, our presenters recorded their abstract presentations, and then they'll be available for a couple of minutes of a short Q&A after each presentation. So our first presentation will be by Dr. Philip, Gasman Simulation Graphics Improved for Free Teaching and Learning.
Actually presented by Maria Chen.
Okay, very good.
All right, is everyone seeing the presentation?
Yes.
See the presentation? Okay, I'm going to start it.
Hello, my name is Maria Chen, and today I'll be presenting a project that I've been working on with Dr. Jim Phillip. Gasman Simulation Graphics Improved for Free Teaching and Learning. The Gasman program simulates inhalation anesthesia pharmacokinetics. It features a picture panel, a graph panel, and an overlay window. You can use the picture panel to control anesthesia administration and watch the compartment still. You can watch the graph panel to monitor anesthesia effect over time. With the overlay window, you can analyze and compare various situations. To distinguish anesthetics in the overlay, each agent is a different color. This is a generic simulation setup in Gasman. On the left is the picture panel with compartments and adjustable fields. On the right is the graph panel, where you can watch the graph be drawn as the simulation runs. Using Gasman's color capability, we differentiated experiment colors to augment overlay visuals. Certain sets of exercises simulate the same anesthetic with different parameters. Thus, we changed each